Perfect, so we're ready to go. Thank you again, Elaine, for coming, and you can take it away.
So the slides are up there, sorry. Okay. Good evening, everyone. So my name is Elaine Cook, and I see there are some people from my hometown, Maple Ridge, BC. I am a pharmacist and a certified diabetes educator, and our topic tonight is self-management skills. So what is self-management? And it's really the behavior or what you do that people who have diabetes or at risk of diabetes in order successfully to manage the disease on their own. Because if you think about it, you know, chronic conditions, not just diabetes, but arthritis, asthma, they're with you every day of the year, 24/7. If you add up all the time, all those 10-minute appointments that you spend with your specialists, with your doctors, nurses, other healthcare professionals, on average it actually works out to only 12 hours per year. That means, you know, you're looking after yourself for 364 and a half days each year. You are in charge of your health. You're the most important person that looks after your health, and you have to find out how you can self-manage it on your own. So that's essentially what this talk is about tonight. So self-management skills follow into a number of ranges. So eating healthy, being physically active, so those are really the lifestyle issues, monitoring different things, but looking after your medications, taking them, using them, developing some problem-solving skills of your own, managing stress, which I didn't list here, and then looking after doing everything you can to reduce your risk of complications. The ones that I've highlighted there is what we're really going to have more focus on this evening because this is a very large topic and wouldn't really be able to go in depth in it all in just 45 minutes. So healthy eating for people with diabetes, in fact for all Canadians, is really following the Canada Food Guide. And if you look in the Canada Food Guide, it actually gives you some examples of the types of foods that fall into the 4 food group categories. In that section there, it'll give you some idea of what a serving size is as well, as giving you some idea of what, you know, eggs fall into meat and proteins, for instance. Looking at the other side of the food guide, you find your age and your gender, and it gives you a guideline for how many servings of each food group that you should complete every day. And then when you go back across the side, you can see what those servings should be comprised of. And these are just examples. So this is just one example that I found of describing a healthy eating. And in fact, the more colorful your plate can be, the healthier your choices are. Essentially, you want to have at least half of your plate being in the veggies and in the salad vegetables. The whole grains are a quarter of your plate in your starches, and this would also include your potatoes, your pastas, your rices, noodles, peas, and corn are actually a starch. A quarter of your plate should be your protein. It can be plant proteins, it can be animal proteins, and you want to usually have fruit for dessert more often than having cakes or cookies. Try to have drinking more water or have a small glass of milk or a soy beverage to complete your meal. And to look at this type of arrangement for every meal that you do. Another way of looking at healthy eating is that you have your own measuring devices with you all the time. So carbohydrates, which again is your grains, your starches, starches and fruits are both carbohydrates, but you want to have maybe a fistful of carbohydrate, your pasta, your rice, your potatoes, and a fistful of fruit. Again, most fruit really is actually about half of a cup. You can have as many vegetables as you can fit in your 2 open hands. For protein, the bigger you are, the bigger your protein portion. So you look at the size of your hand. You want to look at the size of the palm of your hand, about as thick as your baby finger. I had one gentleman who looked at the size of the palm of his hand and wanted to have a 2-inch steak, but we want to look at about as thick as your baby finger for your protein portion. And fat about the size of your thumbnail, because you do need some healthy fats for every meal. And I would advise you to really look at that Canada Food Guide because we don't have a lot of time to go into it tonight. In general, you're looking at the least processed food that you can find. The least processed, the slower it's going to rise up your blood sugar, the easier it is for your body to manage it. You want to look at those natural food states. Look around the edges of the grocery store. So you've got your fruits and your vegetables and your dairy section, your meat section, and you're wanting to look into single ingredient foods. But you want to have something from all 4 food groups at each of your meals. So we're going to talk now just a tiny bit about being active. Nope, I forgot. These are some resources for you. So if you go to the diabetes website, you can actually look under Diabetes and You, under Healthy Living, and then go to Diet and Nutrition, and you will find all of these resources there for you to look at. So when we're talking about being active, we don't want to be couch potatoes, because really exercise is medicine. It helps us lower our blood pressures. It helps us lower our blood sugars. It helps reduce stress. It makes you stronger. It is, we'll step at that. So regular physical activity, if you're looking at the guidelines, the Canadian Diabetes Association, the minimum amount of exercise that you should be aiming for is 150 minutes of moderate to vigorous aerobic exercise every week. And you want to look at building that up. That's just your minimum, building up towards 4 hours a week. So you can try for 30 minutes per day for 5 days a week. You could do 10-minute sessions 15 times a week or 3 times a day. You don't have to join a gym. You can just do regular activity like walking your dog, going dancing. You can do jumping. The little section in the middle there, if you are going to do aerobic exercise, it is recommended that you warm up for 5 minutes, check your blood sugar, do your 20 minutes in the middle, and include 5 minutes of cool down, and you can check your blood sugar later if you're concerned. You don't have to check your blood sugar. So the other component of regular exercise, though, is you need to do resistance training 2 to 3 times per week. And often people say, well, what is resistant training? I have to go and lift weights. Well, weights or dumbbells can be part of a resistance, but you could use stretch bands. You could do exercises against your own body weight, such as leaning against a wall and pushing back and forth like a standing chest press. What they recommend is that you start with 1 repetition, 1 set of 10 to 15 repetitions, then build upon that. Go from that 1 set to 2 sets, and then end up with at least 3 sets doing 8 repetitions. I think resistance training is one of the more difficult things for people to figure out. So I'm going to give you some sources here for you're going to get the information. But resistance training is important because it makes you stronger. It maintains a lean body mass or increases it, so it helps with weight loss as well. And it makes you more stable on your feet. As with any regular physical activity, if you haven't been active, you want to start slow and build up. If you have major health concerns, especially with your eyes, you'd probably want to have a physical checkup with your physician first. So these are some resources. If you, again, go to Diabetes and You, Healthy Living, and under Exercise, there's 9 different pamphlets, and it actually includes some demonstrations, some information for you, diagramming what is resistant training and how to do it. So monitoring, self-monitoring of blood glucose. The targets in the Canadian Diabetes 2013 guidelines are to aim for 4 to 7 millimoles per liter, which is what you're going to get on a home blood glucose monitoring. For fasting, which means you haven't eaten for 8 hours, or it's traditionally in the morning, and that same number before each of your meals. 2 hours after eating, your blood sugar needs to be in that 5 to 10 millimole range. But if your A1C, and we're going to say what A1C is again in a few minutes here, but if your A1C is not at target, and the target is less than or equal to 7, then 2 hours after meals, you need to be aiming for 5 to 8 millimoles. So when you are monitoring, you want to use those glucose readings to do something. You always want to be testing with a purpose. You don't want to test just to get a number, to have a number written down. one of the things that is important is that you don't just have diabetes in the morning. And a lot of people only test at that time of day. If you are going to test, you need to vary the time of day. When you have enough numbers to look at, you want a problem solver to figure out what can you do to make changes when your blood glucose values are not within those target ranges that we just talked about. If your goal is to make changes to what you're eating, then it would be recommended to check before you eat and 2 hours after you eat. And write down what you're eating. If your goal is to figure out how exercise helps your blood sugar, then check before and after exercise. Often I tell people to write down on a level of 1 to 10, what is their stress level? You might find a pattern that you're always stressed in the afternoon, and then you can look at doing some stress reduction. So again, can't stress this enough. You always want to test with a purpose. And when you are testing, blood glucose monitors, yes, they all have memories, but they don't tell you what did you eat. So if you're wanting to make changes, you need to know things that affect your blood sugar. The amount, the quantity of food, the type of food, the type, how strenuous, the length of exercise, what medications you took, how stressed or how sick you feel, because sickness is another way of stress. But test around those types of things when you want to make changes. Example, the food again, before and 2 hours after eating. But you shouldn't make changes just based on one blood sugar reading. You need to have some kind of a pattern develop. So if you're testing for exercise, you're going to have to do it over a number of days and see if the same thing is happening. When we're talking about blood glucose strips, I think it's important for people to realize, and I know there's people from many provinces on here, but Ontario has already restricted how many strips that they will pay for a person in a year, and BC may soon follow it. What's happened in Ontario, if you manage your diabetes with lifestyle alone, or if you're on medications that don't usually cause hypoglycemia, such as Metformin or Januvia, and we're going to talk about the drugs later, so I'll mention which ones cause hypoglycemia. But if you were restricted in what was paid for you for 200 strips per year, here's a way that they could be beneficial to you. You could use 6 strips in a week, every other week. And when you're in that situation with the low blood sugars, you probably only need to test infrequently. And in fact, you may not need to test at all if your blood sugars are pretty stable. But if you're going to do it this way, you could test one in a week, one evening, and then test the next morning and 2 hours after breakfast. On another day, you could test before and 2 hours after lunch. And on a third day for the week, before and 2 hours after supper. That would use about 182 strips in a year, leaving you 18 to use for some other purpose that you want. But you want to add those up over several weeks. You want to be looking for a pattern. And this is just one suggestion. So we're creatures of habit. We tend to do and eat the same amount of things every day. So this is just one way in which you could utilize that number of strips to get some information. Again, in Ontario, if you're on a medication, an oral medication, that puts you at higher risk of causing hypoglycemia, like glyburide and glycoside, this is an oral medication we're talking about, they're restricting people to 400 strips in a year for coverage. So every week you could do that same 7 strips, but you could do it every week if you wanted to. The bedtime check, and the first thing in the morning and 2 hours after breakfast, another day before and after lunch, and a third day before and after supper. And again, over several weeks, you can add it up and get an average. Another suggestion would be to test one time a day at a different time of day. But I do like testing around a meal better, because then you can write down what you ate for that meal and know where you started and know where you ended up. Just one more thing, if you're on insulin, in Ontario, they've restricted insulin to 3,000 strips in a year, so you can pretty much test the way you are now. So A1C, an A1C, which is also called glycated hemoglobin, the target for most patients with diabetes is to be less than or equal to 7%. The recommendation is that it is measured every 3 months for most adults, or even only every 6 months if the person is consistently achieving their A1C target. So A1C is another way in which your average blood sugar could be determined without doing any testing at all. So this is another option to look at. And you should always know what your A1C is. I don't think it's sufficient for you to go to the lab, get your tests, and never know. My doctor says it's okay. Well, what is okay? You need to know this number. So A1C is different than measuring your blood sugar on your blood glucose monitor. What is an A1C? When you're looking at an A1C, you could relate that to what the average daily glucose number is, the meter type number. An A1C is like measuring your blood sugar every minute of every day for 90 to 120 days and averaging it. So if you have an A1C of 7, that's an average blood sugar of 9.6. That's all the highs, all the lows averaged out. You do want to aim for that A1C of less than 7. Again, all targets should be individualized based on your own personal circumstances, but for the majority of people, an A1C of less than 7 is the goal. If your A1C is 9, then your average blood sugar is closer to 15. So when you're thinking of A1C, what is it? A1C is how much sugar attaches to a hemoglobin inside your red blood cell. So we start out, everyone's the same, diabetes or without. The sugar itself will attach itself to that red blood cell. If you have diabetes, you'll have more sugar attaching to your red blood cell. A red blood cell lives anywhere from 90 to 120 days. That's why the A1C is a measurement of the last, essentially 3 months average of what your blood sugar is, because then the red blood cell dies. So that's what an A1C is. And every time you drop your A1C by 1%, you reduced your risk of diabetes complications by 21%. And microvascular complications, which are eye damage, nerve damage, kidney damage, you would reduce your risk or the progression of it by 37%. And the other numbers are on here, but the first two are probably the most noticeable for most people. So, medication. If you don't take your medication, it's not going to work. It's always for any medication that you take, it's important for you to know its name, what it's for, how it works, how best to take it. If you have troubles remembering to take your medication, ask your pharmacy to put it in a blister pack for you where you can punch it out, usually either morning, noon, supper, or bedtime. Also a good idea to join an automatic reminder or renewal program at your pharmacy so you won't forget to take your medication. One thing with diabetes is that diabetes is essentially a progressive disorder. By the time you're diagnosed with diabetes, the ability of your pancreas to produce insulin is already 50% of what people that don't have diabetes is, and that will continue to grow. With diabetes, insulin is either not able to work, you have insulin resistance, or you have less of it. And people often ask me, well, why do I have to take more than one medication? And I'm hoping that by going through the medications, you'll see that medications work in different ways, and using a combination of them can be helpful. most medications reduce your A1c by up to 1%. So one of the first medications used in diabetes is called Metformin. In the Canadian guideline for the treatment, this is the drug of first choice for most people, even at the very beginning, because it's going to help slow down the release of sugar or glucose from your liver. It's its primary action. It does not cause a low blood sugar. If you were to take it, it doesn't automatically drop your blood sugar. It prevents your blood sugar from going higher. One of the things with metformin is you need to start with a small dose and build up, because often this drug causes nausea, vomiting, and diarrhea. And I've had people come in and say that they're allergic to it because they got diarrhea, but you need to start slow. Even half a tablet once a day. About 3 tablets a day, you get about 75% of the action of this medication. It should be taken with food, and it's commonly taken once a day and building up to 3 times a day, but you can take up to 5 a day. Another group of drugs, which is called thiazolidinediones, another big word, rosiglitazone, which is Avandia, pioglitazone, which is Actose, are not prescribed a lot anymore, but they did help slow down the release of sugar from the liver. There's medications that have an action in your intestines. Glucose or acarbose, it slows the rate of how fast the carbohydrate, the part that your body converts all carbohydrates to sugar, rises. It causes a lot of gas. It needs to be taken with the first bite of a meal. And also, it's one of those ones that is taken a small amount and build up. A newer class of medications that came out about 2 or 3 years ago were called Dpp-4 inhibitors because they inhibit an enzyme called Dpp-4. Every one of us has, when we eat, our body releases a hormone called glucagon-like peptide 1, which helps our body decide when we're full and helps our pancreas release insulin and slow down the release of another hormone that causes the release of sugar. These drugs do not cause low blood sugars, and neither did glucose. So their names, which is sitagliptin or Januvia, saxagliptin onglyza, linagliptin Tradjenta, is a newer class of drugs which are used quite frequently now because they don't cause low blood sugar, and their action is dependent on what your current blood sugar is. And they do not cause low blood sugars, which is really important. They have very little side effects, and they're usually taken once a day. They are a little expensive. Another medication that we see a lot of patients on would be, they call them sulfonylureas, glyburide, gliclazide, which is diamicron, repaglinide, which is glucanorm, and the last one there, the Starlix, I've never dispensed, and I've been a pharmacist for 40 years. So what happens is those medications will essentially say they squeeze your pancreas to make them release insulin. Glyburide, I call it the indiscriminate one because it makes up insulin release no matter what. Gliclazide and repaglinide, their action is based on what your blood sugar is, so they're safer. All of these drugs can cause hypoglycemia or a low blood sugar, but gliclazide would be one of the best choices. I put the Dpp-4 inhibitors on the side here because they help the pancreas release insulin in response to what your blood sugar is, and they slow down the release of a hormone called glucagon from your pancreas that causes your liver to release sugar. So the medication that decreases insulin resistance was those TZDs, thiazolidinediones, the Avandia, and the Actose. And what they did was they helped insulin work better. They helped take glucose into your cells for storage and use. If anyone is still on them or prescribed them, they took up to 12 weeks to work, but they had a very good action. In Canada, these are restricted now. They cannot be used alone because of a study that showed that Avandia caused an increase in cardiovascular disease or an MI, but now they're looking back at that study and showing that it may not be absolutely true. So those may come back on the market soon. So I'm just putting this up because you can see that if you have diabetes, you need to look at different medications to work in different ways to get your blood sugar low, because each medication would have an additive effect. As of next week, we're going to have a brand new class of medications available. We're going to have a great big name for them. They're going to be called SGLT2 inhibitors, sodium glucose transport 2 inhibitors. This is very new because they're going to work on your kidney. And what they're going to do is they're going to make your kidney pee out more sugar. And they will have an effect. They don't cause hypoglycemia too much by themselves. They actually will cause a bit of weight loss, which is a positive. And they can lower your blood pressure as well. And they're brand new. They're going to be coming out next week with one called Invokana or canagliflozin. And you can learn more about that when they're available. Some of you may have heard of medication liraglutide or Victoza. This is an injectable medication that causes the action of GLP-1, that hormone that the Dpp-4 worked on, to be bigger in your body. So these two drugs, Victoza and Byetta, they make your pancreas release insulin in response to what your blood sugar is. They slow down that hormone glucagon that comes out of the pancreas to make your sugar rise. They delay stomach emptying, so they delay the rise in your blood sugar for after you eating. They make you realize when you're full, which is something that when you have type 2 diabetes sometimes disappears. And they can often promote weight loss. The average weight loss is only 12 pounds, but we have heard of people losing a lot more medication, a lot more weight than that. They are by an injection, and they are a very expensive medication. They do seem to work on all the physiological changes that occur in your body. Your body has to be able to produce insulin in order for these to work. And they make you quite nauseous at the beginning, but that tends to go away. Or if someone who is on it, if you're having a lot of nausea, eating smaller, more frequent meals is usually a solution to that. So insulin, insulin is the hormone that's missing in diabetes, and there is some studies that say that because it is a progressive disease, 60% of people will end up with diabetes, type 2 diabetes, will be on an insulin product. And we have more modern insulins, and I think we delay using insulin perhaps a bit too long because people are afraid and they're thinking of things like, what happened to my grandma in 1950? And we have a lot newer insulins now. So we have regular insulin. These are called human insulins. They're made by DNA technology, genetically modified E. coli. Anyway, we have regular, which is Toronto insulin. We have NPH. We have combinations of those called 30/70 is the most common combination. And then we have brand new insulins. These insulins work closer to what happens for people who don't have diabetes. We have Humalog, and it also comes in a biphasic mix, which would be like all of it's Humalog, but part of it is made so it works longer. And we have Noble Rapid, or Aspart, and we have a long-acting one which is used a lot in type 2 diabetes called Lantus or Glargine, and another long-acting one called Levemir. If you are on insulin, you need to make sure you know when does it work. So this is just a little example here. So bolus means mealtime insulins. The analog insulins, those rapid-acting ones, Lispro and Aspart, or glucine, which is called Apidra, they start to work within 10 to 15 minutes, and they last for up to 4 hours, but their main action is over in an hour. This is very close to what happens for people who don't have diabetes. We have regular insulin, or also called Toronto. It can take 30 minutes to an hour to start working, and it can have an action for 6 to 10 hours. If anyone is taking an R, Toronto, or a 30/70 insulin, they need to inject it minimally at least 30 minutes before a meal so that it starts to work when your blood sugar rises. Unfortunately, sometimes with this particular insulin, you're often having to feed your low blood sugars because it has a longer action of time. And then basal or background insulins, we'll call them. We have NPH, which is the human insulin. It takes about 4 hours to work, and its action is anywhere from 12 to 24 hours long. And again, because it doesn't actually mimic what happens in a non-diabetic, often causes a lot more low blood sugar. So R and NPH cause more low blood sugars than does that rapid. And we have our long-acting insulins, which is the Detamir, or Levemir is its brand name, and Glargine, which is Lantus, which essentially take about 90 minutes to work, and they're used as a background that our bodies require a small amount of insulin all the time. So I thought this might be easier to explain. That gray part, that's what happens for someone who doesn't have diabetes. When someone without diabetes eats, they have a rapid release of insulin. It covers the meal, and it goes down. And the little bit of insulin that goes all the way across the bottom is that background need. So if you have a regular insulin, like R, Toronto, you can see it doesn't actually mimic what happens in a non-diabetic, and that big space you see between the gray and the blue line is often where you might have a low blood sugar, or you might have to eat more frequently to cover it. The light blue line, which is that NPH, that also doesn't mimic normal action in someone who doesn't have diabetes, and again can cause a low blood sugar. Compare that to the analog insulins. So we have our rapid acting in that little orange. So they work a lot like someone who doesn't have diabetes. They work fast, they have short major action, and they're gone. And then the Levemir or the Lantus works for that background amount. So anyone who's on insulin, when you're using it, it's just kept at room temperature. You do not need to refrigerate. It's good at room temperature for 30 days. Levemir works for 42 days. Cloudy insulin, such as a biphasic mix or 30/70 or the Humalog mix 25, you need to resuspend it. You never shake insulin. You rock it back and forth 10 times. You roll it back and forth 10 times. It's very important to learn how to properly change where you're injecting. It's called rotation of the injection site. I'm going to show you a little picture for that. You always want to use a new needle and rotate to avoid what's known as lipohypertrophy, which is a thickening of the fat tissue underneath. And you need to, I will explain that one in a second. And needle lengths don't need to be very long. They come in 4 millimeters. You really don't need anything more than that, but never use more than 6 millimeter needles. When you put them in, it's just at a straight in, 90 degree. You depress the plunger slowly, and then you count to at least 10, preferably 15, before you remove it. And by counting and not jabbing, you shouldn't have any bruises and you shouldn't have any leaving. So what is lipohypertrophy? Lipohypertrophy is growth in the fat tissue underneath, which is an insulin challenge. Insulin has a growth property, and it can happen if you repeatedly inject into the same spot all the time, if you reuse your needle, and you're not palpitating. So you stand up, you palpitate your area where you're injecting to make sure there's no hard lumps or squishy areas. And the little picture where the girl is pinching, you can pinch it closer together when it's normal skin, but if there's this lipo underneath, you can't pinch it together, because insulin is only to be injected into the subcutaneous layer. Our skin is no thicker than 2.4 millimeters. You just need a short little needle like a 4 or 5 millimeter. To press the plunger, it makes that little pool, and then it dissipates while you're counting to 10. When you do inject, you always want to stand up and palpitate the area, make sure that there's no lipos. You want to use a postcard-sized area of skin. The abdomen is the most frequent area used. And you want to rotate every injection during 1 week during one of those sites. So, for instance, site number 1 here, you would use it for 1 week at a time, moving it around each time, and then the next week you'd go to the second site. The third week you'd go to the third. The fourth week you'd go to the fourth. If you are a person on insulin, you've always been injecting in the same site, and you find that you have some of that hard or spongy or lumpy material underneath, you often need to change your dose, reduce it by about 25% when you go to a new site and build up. Abdomen is the most common. Another site is the thighs. You can also use the back of your arm. So problem solving. We've been talking about problem solving for blood glucose, looking what causes changes and to look for a pattern and make a change on your food or your exercise or else. But you need to learn how to properly goal set, because goal setting is going to help you solve your problems. So your goals need to be specific. You need to know what it is you're going to do, how you're going to do it, when you're going to do it. They need to be measurable. You can't just say, I'm going to lose weight. You need to know that you're going to lose 2 pounds or 4 pounds. They need to be achievable, not easy, but something you might have to stretch yourself for. But if it's important to you, something that you could achieve. They have to be realistic. You can't say, I'm going to lose 20 pounds in the next month. It's probably more realistic to you to say, I'm going to lose 2 pounds this week. It needs to be timely. You need to have a start date, and you need to have a date that you're going to achieve it by. If you don't give yourself a date, you'll never get started. So it's very important to make all of your goals SMART. So for an example, how would you eat an elephant? 1 bite at a time. So if your goal is to eat an elephant, you need to break that down into mini goals. What do you have to do? You got to get the animal to the butcher, and it's got to be by Saturday, because, you know, the meat might get a little bad before then. You're going to freeze it, can it, or smoke it by next week. You got to have some recipes so that you know what you're going to be able to do to cook these, and you got to plan your menus. Then you've got to decide, well, what can I do? What action can I take to complete these tasks? So once you decide what your goal is, you have to think of all of the steps that you need to do in order to get you closer to your goal. Be this weight loss, exercise, or whatever. In our elephant scenario here, you got to get the elephant to the butcher by Saturday. But those have some tasks too. You have to hire a truck and crew, got to decide how you're going to get the butcher to cut it up and wrap it, what sizes, what quantity, where is it going to go in your freezer. You have to also think about what's going to stop you from carrying out your action plan. If you say you're going to exercise every day, what happens if it rains? But for our elephant scenario here, we've got to hire a truck and crew. So we need some phone numbers of a couple of companies in case availability is a problem. We know the elephant weighs 8,000 pounds, so we're going to need a crane to lift it into the truck. We obviously need more than one freezer. Know what you're going to do to get past the barriers that you have. If you have a barrier, you can't get out and walk because it's raining, are you going to get an umbrella? You've got to think about all the barriers. What's going to stop me from doing my plan? And then think of a way around it. You also have to decide, well, how confident am I that I can actually do that? Pick on a scale of 1 to 10. How confident are you that you're going to be able to carry out your plan? If you don't feel that you're at least 7 out of 10 confident, change your plan. Readjust it until you're confident that you have a 7 out of 10, 70% confidence that you're going to do it. Your plan's to walk 2 kilometers every day, but you're only 5 out of 10 confident. But if, say, I'm going to walk 2 kilometers on Monday, Wednesday, and Friday, rain or shine, and you feel 8 out of 10, you're going to be able to do that one. At the end of your time frame, I'm going to lose 2 pounds by June 15th. You want to look back at what you've done And any positive movement forward, congratulate yourself. You want to think about what worked, what didn't, and use your information to decide your next action plan. In our elephant, the meat from the elephant was too much for one family, so we had to have a donation area designated so we could give it out. The last thing we're going to talk about is risk reduction. It's very important that you know your ABCs. Your hemoglobin A1c, which is A1c, your target is less than 7. Where are you? Your blood pressure. Blood pressure control is as important or maybe even more important in preventing and decreasing your complications than blood sugar control is. So your target for your blood pressure is 130 over 80. Actually, I wrote that wrong. So it's 130 over 80, ignore my slide, or less. Your cholesterol. Diabetes is a blood vessel disease. You need to look after your blood vessels. So you need to know what your cholesterol target is. The target is to have your bad cholesterol, the LDL, to be less than 2, or at least to reduce your cholesterol by 50%, your LDL, than what it is now. A dilated eye exam to check for microvascular damage, for retinopathy. For type 2, you get that exam at diagnosis and every 1 to 2 years. If there's no retinopathy present for type 1, it's 5 years after diagnosis, then every year after that. If you smoke, stop. It's a cardiovascular disease. It's a blood vessel disease. You have to protect your heart. Neuropathy, which is nerve damage, you have to look at your feet. I believe the seminar that last happened was talking about foot. So you want to check your own feet every day, and you want a healthcare professional to check them at least once a year. Kidney disease. Kidney disease is usually started progression by the amount of protein in your urine, and they will assess your renal function. So at type 2, at diagnosis, and every year, again, type 1, 5 years after, and then annually. You have to control your weight. Being a healthy weight is going to help you with your blood sugar. Your target is, let's call it 19 to 25 BMI. Waist measurement in men, you want to aim for 40 inches or less, and in women, less than 35 inches. So one of the things I want you to think about is it's not just about blood sugar. When you're looking at your blood sugar, you want to monitor your blood sugar when needed, when you're going to do something with that number. Don't test to just get a number. Know what your A1c, hemoglobin A1c, is. Less than 7. Do you need to make changes? What's going to control that? Your exercise, your lifestyle changes, your oral medications, you're taking insulin, you're taking the GLP-1 non-insulin injectables. You need to be looking after your cholesterol and your blood pressure. You need to know what your targets are, because these are things that are really going to put your risk of cardiovascular disease. So you need to be looking after your heart and your blood vessels. So for cholesterol, you have to look at your lifestyle. Exercise will lower it. What you're eating has a big effect. You want to, if you smoke, stop, and you have medications to take. For your blood pressure, you need to monitor your blood pressure if this is a concern for you. Less than 130 over 80. Lifestyle, what you eat and your exercise makes a big difference to your blood pressure. Again, no smoking. If you're given medications, you should take them. Cholesterol and blood pressure are silent diseases. You often have no symptoms. It's important to take your medication regularly. Microvascular, which is nerve damage, eye damage, kidney damage, right? You have your kidney function assessed, you have your eye exams regularly, you check your own feet, and you don't smoke. So just to the end here, remember you're in charge of your diabetes. You're the most important person on your healthcare team, and it's what you do that can make a big difference. Self-management can lower your A1c 0.5 to 1%. Look after your lifestyle, eat healthy, and get some physical activity. If you're monitoring, monitor with a purpose. If you're on medications, you want to take them for all conditions. You want to use goal setting to get farther ahead, and you want to manage your risk of complications. And that is the end.
Hello?
Hi.
Sorry, I had you on mute there. So much. That was a great presentation. It was always good to see the SMART goals kind of in practice and applicable to various scenarios. So we're just going to get down to the questions portion of this. For everybody there, if you have any questions, please type them into the QA box, and then we'll address them right now. So we'll start for the first one here. From Linda, she says, I recently noticed that skim milk has more sugar content than, let's say, 2 or 1%. Which is best to drink?
I think with the milk, you have to be thinking about not just the sugar, which is probably not a big issue unless you're drinking 8 to 10 glasses of milk in a day, but even that's not a big issue. It's the fat content that's really important for your diet. So if you can manage skim milk, go for it. Some people don't like the flavor. So 1 or 2%, all are equally good choices for you to make.
Mm-hmm. Okay, great. Another one from Linda here. In the beginning of the presentation, you were talking about A1c and sort of throughout it. She just asked, what does it stand for?
So A1c stands for hemoglobin A1c. Hemoglobin is the part of your red blood cell that contains the iron, and it stands for glycosated hemoglobin. How much sugar is stuck on your hemoglobin?
Okay, perfect. The next one we have is from Linda. I'm a type 2 on insulin. I've read studies that say that insulin is a cause of weight gain, and what one should look at is the metabolism. Any thoughts?
So yes, insulin definitely can cause weight gain. And part of that weight gain is often the freedom that insulin will give people depending on when they're taking it. So, if you know insulin's going to bring your blood sugar down, people tend to eat a little more. It gives them a bit more freedom. But it definitely is something that can be managed. On average, weight gain is usually 5 to 10 pounds with insulin. You do need to, whenever you start on insulin, check with your dietitian. Some people will go on insulin so that, it depends on what kind of insulin too. If you're talking about Lantus insulin, very little weight gain. Levemir is a long-acting one that has said that it actually causes a bit of less weight, but you still have to be looking at your exercise and what you're eating when you're on insulin. Remember, insulin is the hormone that's missing in diabetes.
Okay. So I'm just scanning through our questions here. From Marge, I test my blood in the morning before breakfast, then run approximately 1 hour, and then test again. It is always higher after my run, even though I haven't eaten anything. Why?
Part of the reason for that is remember that your liver looks after your blood sugar, and it's going to release more sugar as needed. And with the exercise, there is some cases, and exercise is one of those really difficult things to explain because in some cases exercise lowers your blood sugar, but if your blood sugar was higher to start with, you can actually end up with a higher blood sugar later. It's actually a really involved process, and it's one of the things that's very difficult for athletes is this management of your blood sugar because it can go the other way, whereas most people, an exercise is going to lower it, but if you have really vigorous exercise, it often will cause it to rise. And I'm sorry I don't have a better explanation than that.
No, that's great. Thank you. Question from Pat here. She says she has type 2 diabetes diagnosed 7 years ago. She's managed it with diet and exercise to date, and she was told that she will eventually need to go on medication. Is it true, or is it realistic to expect that she can maintain control with diet and exercise alone?
I believe there's some statistics that say that about 20% of people could manage their diabetes with exercise and lifestyle, but it's extensive exercise and lifestyle control. And the longer you maintain your A1c at around that 7 or less number, the less likelihood that you would progress to insulin. Although I think a fear of insulin is something that is everyone has, it's with the newer insulins and the newer injections, I think insulin is an excellent choice, but it's just another choice. With some of the newer medications like the GLP-1 analogs, Victoza, liraglutide, which kind of address all of the changes that occur physiologically, we may see more and more people never getting to insulin. However, diabetes is a progressive disorder, and it may eventually progress there. But there are people who have pre-diabetes, or it was just, they had the very beginning of diabetes, and extensive exercise. For people who are at risk of diabetes, they did this control study. And people that did extensive exercise, so they lost 7 pounds, they exercised 150 minutes a week, and they ate very healthy, and they learned how to eat healthy. They decreased their risk of developing type 2 diabetes by 58%. So definitely lifestyle makes a huge difference, and all the more power to you if you can stay off any medication.
Great, thank you. A question from Iris. Could you please enter the name of the new diabetes medication that is scheduled to be released next week?
I did see someone enter it over in the chat.
Yeah,
it's
I believe I did see that as well.
Invokana. So Invokana. The generic name is canagliflozin. Maybe I can type. I'm not sure. Let me see if I can type here. Okay, here we go. C-A-N.
There you go.
A-N. Oh, I like capitals apparently.
Hmm.
And it's by our sponsors for tonight's.
Oh, perfect.
Yes, it's by Janssen Pharmaceuticals. And really, I really think it's going to be a real positive for people. It does have a slightly increased risk of urinary tract infections and mycotic or fungal infections, but it is usually a one-time thing that tends to go away. It lowers your threshold for putting out sugar in your urine, so you pee out some of your sugar, on average about 300 calories worth of sugar per day. So that's why it causes weight loss. So that's like 2,100 calories in a week. So on average that has lost about 4 to 10 pounds, I believe, as well.
Wow.
So another tool to use.
Definitely. Question here from Michelle. You spoke about reduction of a percentage of A1C. Did you mean to say from 7.3 to 7.2?
No, a 1% reduction would be 7 to 6, 8
to
7, 9 to 8.
A 1%, yeah.
1% reduction.
A full percent.
I will tell you, though, if you're looking at your A1C and your A1C is 7.3 or less, if you're wanting to lower your A1C, you then need to be looking at your 2-hour after meal blood sugar when your A1C is less than 7.3.
Okay, great. I'm just looking at some follow-up questions about the A1C. They missed the data on the slide regarding A1C, the 5 to 8 mmol, and what that represents, if you could review that.
Oh, okay. Let's see. How do I find the slides again?
Let's see here.
I think it would be about slide number 24 or so.
Okay.
Oh, I can look up here on the side. Okay, let's see.
I know, I just pulled up our side here.
All right, so...
I see some A1Cs here.
Oh, look at that. You're better than me. Okay, so A1C. The target for A1C is to have it to be 7% or less for most people, okay? And what is the A1C is how much sugar is stuck. So when you're looking at this average, because some people come in and they say, oh, my A1C is 7, so that must mean my blood sugar is 7. So when you take a test on your blood glucose meter and you get a number, say you get 8 on your blood glucose monitor, that is 8 millimoles per liter. So the millimoles per liter is the kind of measurement that your blood glucose meter gives, whereas the lab test that you go and get, and it's called the A1C, hemoglobin A1c, glycated hemoglobin, all those names apply. That's a percentage number of how much sugar is actually stuck, and it's compared to someone without diabetes. So A1c of 7 is an average blood sugar of 9.6. You might have 4 to 7s before a meal and 5 to 10 after a meal. But if you averaged all of the readings, every minute of every day, 24 hours a day for 90 days, that's what that 9.5 average, it would be like the number you would get on your blood glucose meter if you were willing to test every minute of every day. People will tell me, but the average on my blood glucose meter is this number, so doesn't that mean my A1C is that number? But when you test on your blood glucose meter, how many times a day you're testing? If you test before each meal and your average is 5, that doesn't include any of the other times of day, where an A1C is all times of day for 90 days.
Yeah. Okay, great.
That answered.
Yep. Question for Sam, when you're talking about the food groups, when you're eating all food groups per meal, how much food is allowed the whole day?
So then you want to go back to the Canada Food Guide. Sam, if you are, let's say you are 50 and you're a man, so then your fruits and vegetables, you'd have 8 to 10 servings per day. Fruit has a lot of sugar. So I always tell people, if you are allowed 8 servings per day, rather than 4 fruit and 4 vegetable, maybe you should have 3 fruit and 5 vegetable. So you could have your fruit as your dessert. But in the whole day, you could have, let's go with the 8 servings if you have diabetes. A serving is half of a cup of fruit. So that would be, if we're saying, I said 4 servings of fruit, so that would be 2 cups in a day, right? Half of an apple is half a cup.
Okay. Another one from Howard here. I have problems with my feet, so this restricts my ability to walk, etc. What should I do?
Swimming is a really great exercise that has no weight bearing on your feet. And any kind of exercise, sitting in a chair, doing chair exercises can be beneficial. So you always have to look about what your limitations are and what can you do. And you sometimes need to be creative. Sitting in a chair and doing weight bands, resistance bands, can be helpful, moving your feet up and down. And as I said, swimming is a great non-weight bearing exercise.
Great. And our last presentation was actually on fit assessment. So
good.
All of our presentations here are being recorded and they will be uploaded, and you'll get some more information on that later on. Another question, if a child is overweight but healthy, do you have to suspect any diabetes is going on?
Being overweight is not the only reason to be diabetic. However, we have a huge increase in the amount of childhood diabetes because we have so many overweight children. So it is definitely something that is often considered. In small children or children under the age of 12, you will often see some of the traditional signs of diabetes, like they're thirsty all the time, they pee all the time, they're hungry all the time. But of course, the only way of knowing would be to express that concern with your physician, and he could run some tests. But when I first became a diabetes educator in the, early 2000s, childhood diabetes, we didn't see a lot of it, and yet now BC Children's Hospital has regular type 2 diabetes clinics and a larger number of patients. And being overweight is definitely, so the best thing you can do for your kid is to try to help them manage their lifestyle issues now.
Okay. Another question here. One of our listeners said, I just got diagnosed with type 1 diabetes 2 weeks ago. I like to drink alcohol socially. Any tips?
So when you have diabetes, once you have brought it under control, so control being an A1C of less than 7, blood sugar before a meal 4 to 6, 4 to 7, 2 hours after meal 5 to 10, and once you've reached that control, they do say that if you're in control, you can have 2 drinks of alcohol per day. Actually, on the Canadian Diabetes website, if you go under alcohol and diabetes, there is actually a pamphlet available that talks about alcohol. It talks about differences and how much a serving size is. It talks about, beer has a lot of carbohydrates, and it does give you a guideline as to what you can drink if your blood sugar is in control.
I guess that's the key there, if it's in control. Perfect.
In control. Remember that alcohol is a sugar, right?
Yes, exactly. Another question here. Does stress raise your blood sugar?
Definitely. Stress raises your blood sugar, and sickness can be stress, and bad and good things can be stress. So that's why I did mention that when you're measuring your blood sugar, you might want to record a feeling of how stressed you are. So if you had someone who's been sick for 3 weeks, their A1c might even go up because their blood sugars when you are stressed can be definitely higher. So the stress hormones cause your body to release more sugar. It goes back to flight or flight. Your body gets ready to act. So it causes more sugar. That's the energy for your cells.
Great. I'm just reading, you're typing into the chat box the name of the medication. Did you press enter on the chat box?
You have to hit enter too, eh? Okay. All right. Sorry about that.
No, okay. I saw your, there you go. Perfect.
I haven't done a webinar before, guys.
No, you're doing great. Perfect. Thanks for that. And if you want to review what SMART stands for.
Sure. So SMART is what your goals need to be. They need to be specific. So you need to know exactly what you're going to do, how you're going to do it, and when you're going to do it. You need to be measurable. If you can't measure it, how are you going to know if you achieve it? So if your goal is to exercise for 15 minutes 3 times a week or whatever, 30 minutes 5 times a week, you need to know what it is. You need to have something. You can't just be, oh, I'm going to lose weight. That's not measurable. I'm going to lose 2 pounds. That's measurable. It has to be achievable. It has to be something that you need to stretch for, so not easy, but it has to be something that you believe that you can do with a plan. It has to be realistic. It can't be, I'm going to lose weight and look fantastic in my new clothes. It has to be, I'm going to lose 1 pound a week. People look at me when I say 1 pound a week, but 1 pound a week is 52 pounds in a year, guy. So, and it has to be timely. If you don't give it a start date and an end date when you're going to measure your progress, you'll never get started because I can always do it. But if you say, I'm going to start tomorrow, I'm going to exercise 10 minutes 3 times a day, and I'm going to keep track of it on this little chart, and I'm going to see if I've achieved this by 2 weeks from now, or pick a date, or the weight date, or any other goal date.
Okay, great. So I see you put the medication up there, and I see a follow-up question. Is it fast or slow insulin?
Insulin, is it fast or slow? So we have different kinds of insulin.
Victoza.
Oh, Victoza?
Yeah.
So Victoza is not insulin. Victoza is a hormone replacement. When we eat, a hormone is released in our intestines called GLP-1, and it is quickly gotten rid of by Dpp-4, an enzyme. So when we give it to our bodies, Victoza, we're adding to that GLP-1, and it's resistant to degradation. So GLP-1, our naturally occurring hormone, makes our pancreas release insulin in response to what our blood sugar is. It makes the hormone glucagon be suppressed because that's what raises your blood sugar. It makes you realize when you're full again. It slows down that emptying from your stomach so your blood sugar rises more slowly. But it's not insulin. It is a non-insulin injection.
Perfect. Thanks for that clarification there. We had, I think, 2 questions here about swimming and exercises. Does swimming and deep water exercise take care of resistance training?
If you just swim, it's not weight-bearing. So resistant exercise is bearing some kind of weight. If you're in deep water and you are moving through the water against the weight of the water, that can be considered some resistance training. But just swimming on the top of it and diving is not considered resistant training. So if you had You need to do weight-bearing exercise. Swimming is not a weight-bearing exercise. The water is buoyant.
Okay, great. Another question here. If I am successful at losing weight, is it possible for me to to be able to go off metformin?
Well, you actually have to see what happens with that. Remember that diabetes is a progressive disease, and weight loss helps control it. But it's not necessarily going to take you off of all your medications. You might lose weight and be taken off of it. I'm not saying that you can't, but it certainly would be something that you would do along with your physician. People who lose weight often need less insulin. They are less insulin resistant. So yes, the needs of the insulin would change.
Okay.
Or metformin or glyburide, all of them.
Yeah, okay. From Linda here, genetics, does that play a significant factor in diabetes? I have 3 members in 3 generations that have diabetes.
If you have relatives that have diabetes, type 2 diabetes, you are at greater risk for developing type 2 diabetes. What they say is it can be a combination of genetics and environment. As I said, not all people who are overweight will ever develop diabetes, but if you have a predisposition to developing diabetes, that weight or the inactivity would definitely probably make it come out more. But yes, you have a greater risk of diabetes when you have a relative with diabetes.
Okay, great. Question for John, from John, sorry. With exercise, medication, and diet, I am in control of my blood sugar. I totally avoid sugar and processed foods. Sorry, my thing's scrolling here. And I add a lot of fiber in my food. Am I doing the right thing?
It certainly sounds like it. I mean, you do want to have at least 25 grams of fiber, and lifestyle, eating healthy and exercise is a huge component at all times, no matter where you are in your diabetes. And it certainly sounds like if you are blood sugar's in control, you're eating healthy and everything, you're doing the right thing.
Okay. We have a comment here from one of our listeners to say, I do water exercise and 1 hour has been deemed as 6,000 steps on the pedometer.
Well, I'm not aware of that, but if you're doing exercises standing in the water, again, you're doing it against the weight of the water. So yes, you're doing some kind of resistant exercise. As far as the pedometer goes, most pedometer programs talk about 10,000 steps in a day.
Okay.
I have no idea, but you can probably look it up as how much calories water exercises burn.
Okay, that's a really good point there. Another question here. What health teaching do you give to a patient who does not check his blood sugar readings but says that he manages it by lifestyle?
Usually if a person is managing it by lifestyle and they are having an A1c check every 6 months or even a year, and their A1c is in control, there is no reason for them to check their blood sugar. What are they going to do with the number? A lot of times you can use blood glucose checking at the very beginning of diagnosis or occasionally to see how that food is being processed or how the exercise is being processed. But people who are managing by lifestyle do not generally need to check their blood sugar.
Okay, thank you.
There is now, and maybe Andrea might know where, but I believe last week there were 2 new apps, we'll call them, that talked about self-management of blood glucose monitoring. One was for healthcare professionals, and one was for people with diabetes. And I did find them in the guidelines under resources for patients, and you put in your answers. What's your A1c? Are you on this type of medication? Are you sick, etc.? And it gives you a guideline of when to test. But in general, if you are on lifestyle alone, you do not need to test because you're not going to do anything about it.
Yeah, perfect. It makes sense. Okay, so it looks like we're at the end of our questions. If anybody has any last-minute questions, feel free to just type them in the QA box. I'll just wait about a minute or so, and then I'll see if anything pops up there. And I'm just going to look at a quick scan of our chat here, so it looks kind of quiet for now. So I'll wait again another minute until questions come in. I'll just keep on going here and check in at the end. So I just want to thank everybody who attended the webinar tonight and for all the volunteers who coordinated this session. I'd like to remind everybody that you will be sent an evaluation survey tomorrow and really encourage you to complete it. The survey should only take about 2 minutes and provides valuable input for our association. This spring webinar series is generally supported by Janssen, as you mentioned, Lilly, and Novo Nordisk. And the development and delivery of impactful programs such as our new Canadian Diabetes webinar series is made possible through the generous support of our donors. If you enjoyed the webinar and would like to make a donation, please visit our website at www.diabetes.ca or call 1-800-BANTING. And thank you so much for your support and for participating in today's webinar. Thank you again, Elaine, for coming in and, or not coming in, calling in, I should say, dialing in and talking to our users. As I mentioned before, these are being recorded. So once we get them going, I believe they're going to put them on YouTube. You will get an email sent out that will have you this, that will have this information out. And so I see one question here just came in through the chat here. If someone with type 1 diabetes tends to skip breakfast and therefore not take insulin, although he takes a long-acting type HS, oh, sorry, I have people typing in here. I got to scroll back. Does not experience hypos in the morning. Should this be a concern?
So taking type 1, skipping breakfast, therefore not taking insulin, although long-acting does not experience. Okay, so if a person who is on insulin is on rapid-acting insulin and a long-acting insulin, in theory, they could go all day without eating if their long-acting insulin is at the right amount. And then they only take their mealtime insulin, like a rapid-acting insulin, when they eat. So if they don't have a low and they don't eat breakfast, then they don't need it. But in general, we always recommend people with diabetes do eat breakfast to give them energy for the day and to have at least 3 regularly spaced meals.
Perfect. And another question that came in, just for all of these webinars, they haven't put them up yet. They're just working on compiling them and getting them going. So once they are up, then they'll put them all. And then anybody who is registered, they'll send you some more information, probably a link towards the actual sessions, so you can take a look at the recordings here. And that looks like to be the end of it. So thank you everybody so much again for calling in for the questions. And thank you so much, Elaine, for coming and talking to us here.
Okay, great.
Let everybody have a good night. Thank you.
Thank you very much. Bye now.
Bye.